let's go on to the next talk by Dr. Tulio Navarro on early results of transcarotid revascularization technique. So that's very important. Many a times the excess is not only brachial or radial or femoral. The transcarotid approach to revascularization of carotid is a very important approach and a very good approach, especially in cases where you have high embolic risk because of a very hostile aortic arch and a lot of atheromas in the aortic arch, or a very tortuous and bad anatomy to intubate the common carotid artery.
Thank you, Dr. Khanna, again for this kind invitation. Unfortunately, we are not able to travel to go to India. But I'm very honored to be here again. Thank you. We are going to have some talk regarding this transcarotid artery revascularization. Of course, only the early results, our personal with a small sample, but we'll talk about the literature as well. I have nothing to disclosure except that this issue is very, it's a very interesting issue for us in our daily practice, because actually stroke is the second leading cause of death in Brazil. It was the first some years ago, but now it's AMI. And the rationality of this is that 80%, 85% of the strokes are ischemic, and from those, 10 to 20% are from the carotid area. So carotid revascularization would have the benefit of reducing those stroke rates. If we go through the randomized controlled trials from the 90s and the early 2000s, we see that there are some benefits, good benefits in patients with symptomatic high-grade stenosis, but not near occlusion. And the lower the stenosis, the lower the benefit. And it was proved to be of some benefit as well in asymptomatic carotid, but a lower benefit in those cases. So in the, sorry, in the early 2000s, it came the interest of stenting, so we had to compare endarterectomy versus stenting, and we have a few randomized controlled trials. The largest one was the CREST. So we have some good data now to analyze. However, up to the CREST, we realized that endarterectomy had a lower stroke and death rates comparing to stenting. But at long term, after the in-hospital situation, we have similar outcomes. But why? Why we have not good as good as the surgery results in the stenting? Dr. Khanna, he was introducing this topic. He told already, we have issues with access, we have issues with the aortic arch, we have issues with calcified vessels in the aortic arch, in the target artery. We have issues of the wire crossing the high lesions. We have problems with the placement of the filter, with thrombus formation, and the ballooning pre and post. That's inherent to the technique. So in the year of 2004, Chang proposed this new approach. Actually, he called it the TCAR, and he was proposing this as a better carotid artery intervention that had the potential of solving problems of access, of reducing embolization, reducing the need of specialized cerebral protection devices, potentially being safer and more effective. Actually, it is a very simple procedure comparing to the transfemoral approach. We can do it under local anesthesia in most patients with a small incision. Of course, the patient must be very cooperative. On the other hand, you have to go for general anesthesia. We use larger sheaths, an 8 French for the carotid and for the femoral vein as well, in order to put a line connecting between those both introducers, in order to have the reverse flow. So the cerebral protection during this technique is by reverse flow. Here is a diagram. You see that the sheath is inserted in the common carotid artery at the base of the neck, and the other sheath is at the femoral vein. So when we clamp the common carotid artery, there is a reverse flow, and this passes through a small filter.
Thank you for all the help.
And we can also avoid the emboli to go to the brain, and we can also use with a small syringe as well. We can aspirate after pre and post ballooning, pre and post stenting. So there is some measures that we must look carefully. The systolic pressure may not go down under 140, 160. The system is the same as the transfemoral approach. No 14 guide wire with balloons, pre and post, stenting, atropine, and post dilation. They're exactly the same steps from the transfemoral approach. This is an example. We should be very careful with the guide wire of the introducer not to cross the lesion, because we can have a major stroke. So we have to be careful in positioning the sheath initially, and the final results are the same, just the same as transfemoral. Our own casualties, we have 33 patients up to last week. We had 1 stroke with death, no cranial nerve injury, and we have 4 hematomas, but that was needed 1 reintervention. Dr. Mahmoud Malas was the first to publish some results a few years ago, and he compared the TCAR versus the transfemoral approach, and he showed that there was a reduction in stroke and TIA and death as well, comparing to transfemoral approach. But we have some meta-analysis, some very current meta-analysis. This Galifus was from May this year, and he showed us that the mortality rate is very, very low, stroke rate very low as well, a high technical success rate, 1.2 of cranial nerve injury, lower rate of myocardial infarction, but he also had some hematomas and bleeding. We have a more recent meta-analysis from Sagres from October this year, from August this year, with a high technical success rate as well, with lower complication site, access site, bleeding 2% as well, and lower mortality with 0.5%. and a stroke rate of 1.3%, in stent stenosis 1.5%. So in conclusion, ladies and gentlemen, of course, the transfemoral approach is improving, but TCAR is a very promising and safe carotid revascularization approach with favorable technical success rates, with low procedural stroke and cranial nerve injury rates. But we have some issues as well. We must know that optical medical treatment is improving. We don't know yet this for asymptomatic patients. We don't know yet the exact place of the TCAR as well, but there are ongoing randomized controlled trials, and we hope that these randomized controlled trials may be able to answer all these questions. Thank you very much for your attention. At your disposal for comments and questions. Thank you very much, Dr. Khanna.
Thank you very much, Dr. Tulio. I think we had some interruptions, so we'll have questions in the end if you have time.